Good afternoon. I'm Anthony Mingy, Senior Partner for Fitch& Associates. Welcome to our Pinnacle webinar series. Today's presentation is 5 Problems in Patient Transport That Need Fixed Now, sponsored by TraumaSoft. Before we get started, I have a few quick reminders. Registration is still open for Spring 2024 Ambulance Service Manager Program. Space is limited for the class. It's filling up fast. It begins January 22nd with in-person classes March 3rd through the 8th and May 5th through the 10th in San Antonio, Texas. You can register at fitchassociate.com. I also want to thank each of our webinar sponsors. Thank you to TraumaSoft for bringing us today's session. And thanks to our learning partner, Ninth Brain, as well as our premier media partner, EMS One. Moving on to our presentation, we encourage you to use the buttons at the bottom of your screen, chat or the Q&A feature. The chat can be used to interact with your fellow attendees or the presenters. If we have any links, we'll share them in the chat window as well. If you have any specific questions during the webinar, you can submit them using the Q&A button. With that said, I'm pleased to welcome TraumaSoft Senior Vice President Ricky Powell to say a few words about TraumaSoft and get started with the presentation. Ricky, I'll turn it over to you.
Thank you, Anthony. Good afternoon, everyone. Thank you for joining us today. Today, I'm going to talk a little bit about TraumaSoft before we jump into the webinar. As you may know, that TraumaSoft is the only fully integrated EMS management software solution. We have everything from CAD, billing, ePCR, crew scheduler, fleet maintenance, virtual classroom, and many, many more modules. One of the modules that you'll also see as our newest module is Ride Central, and that is a brokerage tool for a modern managed transportation tool. So with that being said, let's jump into the presentation and start talking about 5 problems with patient transport that need to be fixed now. So today we're going to talk about problems that wrap around patient transport. When we talk about types of patient transport systems that are out there currently today, there's 3 different types. We have community systems, that's your 911 systems, maybe MIH systems that are within your community. We have health systems that are managing interfacility transports. This could be hospital-based, skilled nursing facilities, or any health system that facilitates moving patients. And then we have brokerage platforms, which you may be aware of and these are usually controlled by insurance companies or state Medicaid programs. Now, one thing that is common for all 3 types of transport systems is that they experience the same problems and challenges. Now, my background is on the EMS side of the house. I grew up transporting patients, and then I worked my way through and discovered the challenges on the administrative side in managing transports. There's a lot of complex problems that evolve when you're moving transports. Today, we're really going to focus on those health systems. Now, one thing that is common for every health system that we've come across is that you have complex requirements, rules, and regulations. Those requirements, rules, and regulations can be related to laws in your local governments. They could be related to facility contracts. Then our second problem is we have inconsistent manual processes. Just because we've been doing it a certain way for the last 20 plus years doesn't mean it's the right way. Technology has come a long ways, and those processes should be automated. Those processes, we also see incomplete, incorrect data, lots of errors, and then the lack of responsiveness to operational challenges as they occur, and then the lack of transparency between all the different organizations that are involved in the transport cycle. The good news, all of these can be fixed with technology. Let's talk about the complex requirements, rules, and regulations. What makes it so unique is they differ for each type of agency. It doesn't matter if you're a healthcare system that's booking a transport request down to a wheelchair service trying to do a non-emergency transport. to an ambulance provider. And then it gets even more confusing when you throw in your local rules and regulations, your state's rules and regulations, and then even your federal guidelines based on payers. And then you have your facility specific requirements. Each facility might want to manage their patients a little differently, or they have contractual obligations with certain providers or those transport agencies. And those are very specific. And then it comes to the payers. The payers are always governing, maybe have prior authorizations, forms, or a specific letter of medical necessity form. There's all kinds of rules and regulations, and they're very complex. And as we know, not everyone that's involved in the patient transport cycle knows every rule and regulation or is an expert. The inconsistent manual processes really throw a wrench into it as well, because they differ for each individual agency. If I'm at a hospital and I'm booking transportation, I might have a specific set of rules and guidelines. I might need a memorandum of transfer. I might need a PCS form, and all of those are manual processes that I have to complete. If I'm the transport agency, I might have a whole different set of processes that I need to check off in order to schedule that trip. The receiving hospital might be the same, or facility. And then, of course, the responsible payers that's going to be responsible for paying for that trip might have a whole different guidelines. Then, not only associated with those manual processes for each individual agency, each individual level of transport can have a different manual process. We might do things differently for taxi cabs or ambulatory patients compared to what we do when we're booking and scheduling for a critical care ambulance or even an air ambulance. These inconsistent manual processes result in multiple errors, and multiple errors result in inefficiencies and delays within the transport process. We see those errors most commonly during the request or the booking process. So the individuals who are actually scheduling the transportation, they're not billing experts, they're not transportation experts, they're just looking to move their patients. They're patient care experts. They won't know what the medical necessity for each level of services out there. What we're seeing a lot of times is someone calling up and saying, hey, I need to schedule an ambulance trip. Not knowing whether or not, based on the patient's needs, do they need a wheelchair, maybe a taxi, maybe they need a critical care ambulance, but they're just trying to get their patients moved. They don't know the payer specific forms. They're asked, hey, what type of insurance does this patient have? They don't know that they're supposed to fill out a PCS form or even a prior authorization form. Maybe they normally aren't even responsible for transportations, but they're filling in at that specific time. Then they have to enter or give patient demographic information. We all know in a hectic system that is very busy, they don't have the time to necessarily complete and dot their I's and cross their T's when they're giving out that information. And then the last thing, when during that booking and requesting progress, who am I calling to schedule this transportation? Do I have one provider? Do I call a provider or an agency that I'm used to working with? Are they really qualified to move that patient? Are they contracted with the facility? Those manual processes that are often result in errors or incomplete or missing information. Then we move on to the transport events. Those transport events can really lead you to misinformation. What if the transport vendor that accepts the transport really isn't qualified to complete that transport? Are we really getting the right vehicle, the right staff for what we need for the patient? That often causes errors and delays because maybe we accidentally send a BLS truck when it should have been an ALS. Now we have to wait for an ALS crew to do that transport, really causing inefficiencies within the system. Are the timestamps correct? Do we really know when they got on scene? Do we really know when the transported the patient? And then are they on time? If those things are incorrect, are we really moving our patients effective and efficiently? Then our ability for responsiveness to operational challenges. Operational challenges, I could actually list this for days. Because when you're working, you know as well as I do, things change minute by minute within the transportation, what I call as an ecosystem. You have staffing challenges. What if you have a crew call off? What if one of the transport agencies has a vehicle breakdown? What if on the facility side of the house, you have a nurse or a unit secretary call off and now you're short staffed there? And you've got these processes, these manual processes that you have to do. And, and you've never done that before, but today you are doing it. What about the transport agency's availability? What if the system is in overload and they don't have anything? What's your backup plans? How do you respond to getting another provider in there? Do you know what providers to call in the event that your primary provider isn't available? What is the transport agency doing to maximize their utilization of their resources when they're at peak demand on the system? And then, of course, most importantly, what's the bed availability? This can affect a lot of different things within the transportation ecosystem. Bed availability could be the reason we're having transport agency limited availability is because they have a unit in the ER that is on wall time waiting for a bed to clear. What if there was a bed available upstairs, but we don't know that that bed's available because the transport company or the nurse didn't clear that bed? That goes back to the next issue, lack of transparency within those systems. No visibility of what's going on within that whole transport life cycle. Usually, the way we do it now, it requires multiple phone calls. I've got to pick up and say, hey, what's going on with the ambulance? Why aren't they here? I need to move my patient. Or I'm in the ER, or I'm on the floor and I'm saying, hey, I need to get this patient moved to a bed. I need to get this one released. All of those require manual communication, picking up the phone call, being placed on hold, taking away time from actually doing things that matter. There's also little to no integration of the software systems. The electronic health records that the facilities have has massive amounts of information about the patient and things that are going on with that patient. Transport providers and those agencies, they mostly have computer-aided dispatch systems. Those systems have great visibility of what's going on with their systems and their operations. The automatic vehicle locators and GPS systems can give real-time status updates, tapping into those. There's little to no integration. If I'm a transport provider, I have great visibility into my system, but I don't know what's going on with the hospital. If I'm the hospital, I don't know what's going on with my transport agencies. Here's a traditional patient transport model. We take all the things across the top, and as you're looking here, this is your rules, regulations, your government, and you're pouring it into the bucket. Then you have your patient care and your facilities and what's going on with that patient. You're pouring it into the patient transport process. Then we have our actual transport agencies, and then we have the data that each one of those that it pours in. Right now, with those fragmented systems that all comes together, there's a lack of integration. And what happens? It produces unclear results, people not knowing what's going on with their transportation. And it inherently just creates a big mess. So when we started looking at what's going on within the patient transport process, we asked all the stakeholders, where do you start with patient transport? How does your workflow goes? And we got a lot of common questions. And I just put a lot of these up here on the screen. And these questions were from people who had been scheduling transportation for maybe 6 months to 30 years. And they were all the same, and it always resulted in the same levels of frustrations. Those frustrations are those items that you see here in gray in the background. And it really always causes a lot of stress, especially when you're needing to move your patient quickly. A lot of them that was surprising. Should I call for an ambulance or a wheelchair? Do I need a PCS form? What is a PCS form in some cases? And then there was that lack of transparency. Where's the ambulance? Why is there a delay? And then ultimately, annoyed patients, annoyed family members, annoyed staff members, stressed out ambulance people because they're walking into a situation that was beyond their control. Maybe that they've been requesting this transport for 2 hours and they've only been assigned it for 10 minutes and they got there as quickly as they could. All of these create a boiling pot. The good thing is technology can eliminate all those frustrations. We can simplify absolutely everything for everyone. It doesn't matter where you're at within that life cycle. This is a modern patient transport model. We take those same ingredients, all those rules and regulations, compliance matters, everything with the facilities and the patients, transport agencies, all those data, and you pour it into the patient transport process. Utilizing a medical transportation management software, what we do is we build bridges between each one of these items. And what is the result of that is you have standardization, collaborative care, quality data, and better outcomes. And it results in everyone within the transportation model working together with full transparency of what's going on. So let's talk about some modern transportation management platform features. First of all, we've got to utilize software systems to eliminate those errors. Those software systems are, number one, is a medical transportation management software, sometimes more commonly known as a brokerage tool. And then we've got to look at the facility electronic health records, the transport agencies' computer-aided dispatch systems, and then tie those all together with reporting analytics using a business intelligence tool like a Power BI or a Tableau. We're actually building a bridge between all those agencies. We're connecting the facilities with the transport companies, with all that reports and analytics. And what we're building is a roadmap essentially to interoperability. Now, we talked about the transportation management software. We talked about the facility EHR and the transport agency CAD. Those are just good starting points. But to have a truly integrated modern transportation management platform, you've got to include that transport agency's MDT terminals to get data all the way through to the CADs, updating timestamps, real-time visibility, also integrating into their EHR or their electronic patient care record so they can receive the information from that facility's EHR all the way into their EHR. So they have vital patient care information and what's going on with that patient and their needs. And then integrating within that transport agency's GPS or AVL system so we can see full transparency of what's going on once that unit has been assigned. And then tying it into the reporting analytics, having a real patient app so the patient has visibility into who's transporting, even their loved ones and loved ones and their family members can have visibility. And then an online portal for easy access, easy to use, full visibility. And then a way to monitor your system's performance through quality assurance and review. These are essential features to a modern transportation management platform. Now, let's talk about some of the core requirements for a transportation platform. It's got to be the same process every time. And it must be more than just an online booking solution. Now, when you're looking at all these items, the most important thing on here for the end user is it's got to be simple to use. We already have existing manual processes that are confusing. It often leads to incomplete work, and it's hard to use for the end user, not only for booking the calls, but for the transportation providers to just put all those pieces to the puzzle together. This thing has to be simple to use. It's for every user throughout the whole system. systems. It has to be able to be taught, and education is short, not long and cumbersome, and able to become experts in using the system in a matter of minutes, not hours, days, or months. It needs to be compliant. You have to follow all the payer's rules, all the local, state, federal regulations. It needs to do this for the end users. That's where it becomes simple to use. It walks them through the process. Then more importantly, less time, reduce time spent on the phone, multiple phone calls, eliminate those manual processes. Currently, when an end user is scheduling a booking, they'll pick up the phone, they'll call the first provider. If the ETA is not good, they hang up the phone, they go through all the same information with the second provider, and so on until they find a provider that can provide the transportation. We have to have automatic workflows, improve the performance and less time. It needs to reduce cost, reduce the personnel cost, not only within the facilities, but also the transportation cost for the transport providers. Maybe you don't need as many call takers when you're using an automated process that is connecting these systems electronically. It needs to be automated. Walk it through the process, remove those mistakes, remove the barriers to transportation, and make sure we're removing those barriers for reimbursement for the transport providers and shifting the cost from the facilities to those insurance companies. It has to be open. It's got to be able to be used by multiple facilities, multiple users, and multiple transport agencies, and really forming an ecosystem for that transportation network. You have to have smart data. It's got to be aggregated and stored safely. It needs to be hosted in the cloud so it's always up and available and ready. And then you need to be able to do QA and do performance tracking of every stage of the transport cycle. And then last but not least, it needs to be tailored. You have to be able to completely configure it and make sure that those configurations are reportable. And when we're talking about configurations, you need to be able to have lots of abilities to configure it based on type of call, type of agency, type of payer, location, where they're going through. Is it a long distance call? Is it an extended long distance? Be able to modernize this to where it can handle every single scenario through an automated process. Now, let's talk about some of the core requirements. These are automated processes and workflows. When I was talking about making it simple to use and automating things, they need rules and algorithms that during the booking process, the systems are determining the level of service. Now, not only the level of service, medical necessity, matching it to the correct transport agency, on-time performance, everything that's involved in making sure that you're having a modern and lots of transparency within the system. When we're talking about level of service, and Todd could probably speak to this, is what we're seeing in the market is people are just picking up the phone and ordering a wheelchair or an ambulance or maybe an Uber or Lyft without any process or thought going into the level of service that they need. They're also not establishing medical necessity for each level of service. If you have an ambulance transport that's non-emergency, what's the medical necessity for a basic life support ambulance? Establishing that, presenting that to your transport agencies at the time of booking, not after the paramedic or the EMT gets on scene, does their evaluation, determines it's an incorrect level of service. Now you've got two possible solutions. One, bring the right level of service to the patient, delaying the transport, delaying patient care, and also delaying throughput for that facility because now that bed is still occupied. or you transport with that higher level of service and possibly billing that facility as payer of last resort because they scheduled transportation for the wrong level of service. So lots of things that can occur. Automated process and workflows will eliminate and stop that. Then transport agency matching. What does that mean? That means that only wheelchair calls will go to to ambulance, providers or transport agencies that can handle wheelchair calls. If the patient needs a critical care ambulance, let's match it to a provider that provides critical care ambulance. And then the automated workflows also have to make sure that they meet the on-time performance standards for the system. If we have a BLS discharge that the standard is that we're gonna move those patients within 60 minutes, automated systems that go out and find providers that are qualified that can move those patients within those 60 minutes. Those workflows can be complex, but they need to be automated and take that out of the hands of the person requesting. Instead of me picking up the phone and calling, when can you be here? When can you be here? When can you be here? And then determining which transport agency I'm going to use. Compliance. Modern transportation makes sure you're compliant with everything. Federal, state, local regulations, even in compliance with the type of forms that you need to make sure you're moving those patients. The medical necessity forms, physician certification statements, maybe payer specific form, prior authorizations. All these forms need to be electronic and be able to be completed using the data that's within these systems. Some of the other core requirements is you need to be able to have role-based permissions. When I talk about role-based permissions, if I'm within a health system and I need to see transportation I'm a case manager on the 3rd floor, I need to be able to see my transportation for everything that's on that 3rd floor. If I'm in the ED, I need to see in the ED. If I'm capable of signing a PCS form, I need to have permissions to electronically execute that PCS form within the system. Real-time status updates. Where's the ambulance? Where they're coming from? Where are they going? Connected to their AVL, GPS. What's their ETA? Or what's their promised pickup time? Then real-time notifications built within those systems. I'm working. I'm not sitting in front of a computer screen. I might be at patient's bedside. How do I know that I have an ambulance en route on scene? Real-time notifications, email, text messaging within the EHR systems. And then chat functionality. We talked about time on task earlier, multiple phone calls. What we really want to focus on is chat functionality within the software where I can send a message to that transport vendor and the transport vendor can send the message to the facility and they can answer it back and forth. And then that gives you an audit trail, an activity log. You can see all the communications. It's just not he said, she said. That falls back into your compliance. Have a patient app that we talked about. Transport visibility. What's going on? What stage is it in? Has anyone even accepted my booking for a patient to be moved, or are they already en route? And then system monitoring and reporting and analytics. All of those are vital functionalities to make changes for in the future. Now, we talked in the order at the beginning, 5 problems with patient transports. We went through each one of those and what those difficulties are and how you can possibly correct those and what that software system needs to do to be able to help you achieve those goals. Now here's some action items, and Todd, jump in here anytime, grab one that you want. But one of the things that's most important for everybody that's involved in the transport cycle is active participation in local, state, and national associations. This is where you're going to become familiar with your rules and regulations and anything that's coming up in the future, because systems need to be tweaked and make sure that they're current with what those rules and regulations. And when active participation, it's just not in your state EMS association, but actively participate in associations that affect your industry. hospital associations, case managers associations. All of these have lobbyists and PACs that can actively make help facilitate change for the industry in rules and regulations. It's important to know each one of those. Then number two, there's experts out there for this. We're going to go over a case study here in just a minute where Fitch and Associates actually implemented a modern transportation management system for the University of Maryland. And we'll talk about what happened from A to Z, and Todd will walk us all the way through that. Consult with those experts, find out what you need to do. Seek out automated solutions for manual processes. And when I'm saying seek out automated solutions are through technology. Reject outdated software packages, reject manual processes. Use your existing data. You have that data available to drive change and make business decisions. And then last, when you leave here with your action items, partner with agencies to improve efficiencies. We're going to talk about this in the case study, but being an EMS provider for so many years, I didn't like partnering in the private sector. I wanted to run all the transports, do all the calls, do everything. But you have to look at becoming a good partner with not only your facilities, but other EMS or transport agencies. And in return, you'll reap the benefit of efficiencies and improved functionalities within your system. And we'll talk about that. So I'm going to turn it over to Todd now. He's going to walk us through this case study for the University of Maryland. Fitch and Associates was the consulting firm, and they ultimately went with TraumaSoft's Ride Central module for the medical transportation management brokerage tool. Todd, go ahead.
All right. Hey, thank you, Ricky. So actually, I'm going to back up 2 slides to the 5 problems. Part of this that we talk about a lot of times is we have these legacy way of doing things, and out of that, we've been forced to change. What's forced us? Well, rules and regulations have. People have been another reason. We've not been able to all find staff. So we've had to find ways to become more efficient in our process. But we also had to find staff that could do the process and the new process, right? And we had to do it in such a way that you really have to start thinking of easing the path for the frontline provider so that maybe you can take workload off somewhere if you have to add workload on somewhere else. The other piece is doing this by being compliant while still trying to make sure you can bill and collect the revenues you need. All of those issues we're seeing as problems within the system. What we're learning over time is that software has its place in helping us become more efficient, become more consistent in what we do. The other part it does is it really helps not only us make better business decisions, but it helps our partners. When we start thinking of partnerships as we walk through this next little bit of a case study, the partnerships are key. If you aren't partnering with the right partners to do your transport, or the hospital isn't being the right partner, or there's not a win-win for all parties, everyone has a challenging moment. In this situation, what we're trying to do is we're seeing everyone move forward. The hospitals have said, okay, well, we're going to rely on EMS for years. They're going to provide us data. They're going to provide us all this information. But the interesting part is it's almost like we've been kind of for lack of better terms, a black hole of data where it's hard for them to make business decisions on us and how we're planning. So the part of this is really having that good partnership, and where you can partner as an EMS agency, leverage that partnership with the hospital so that everybody can create that win-win. So Ricky, I'll jump to the next slide. So one more slide back. So as Ricky had kind of indicated, we're going to talk a little bit about a case study. I'll bring you full circle with this case study, but the really interesting part was when we were very fortunate enough to partner with the University of Maryland, and we talked to them about this presentation previously, is when we started there, it was how can we just make the system better and more efficient? And as we started to talk through about the ideas of making the system more efficient, then it became, okay, well, how do we pay for that? What's the cost of that? what's a better way of we can work from what we're doing today? As we started to understand this partnership, it made an evolutionary process to where not only the design for how you move forward in command and control, for lack of better terms, at the hospital and its partnership with EMS, but how do you do that in such a way that you have to leverage people, or you have to leverage software, because you can't keep making all these calls by a one-to-one relationship with a person and a dispatch center. How do you ease the situation for everybody? So that was where we ended up with the software. And we'll talk about how we ended up with Ride Central through an RFP process, and then what that did for the system as it relates to the end result. So we're going to walk through this from day one all the way to what's happening today, because I believe, Ricky, if I'm not mistaken, some of the screenshots are actually from just here, like within a week or so, and towards the end to talk about some of the things. Is that correct? Good.
Yes, that's correct.
All right. Well, perfect. So we'll walk through this case study for about the next 15 or so minutes, and then we'll kind of open it up to the floor. So next slide. So kind of setting the stage with the University of Maryland. University of Maryland Hospital is a big system, shock trauma, really large area, and it spans all the way from the shores of Maryland to really downtown Baltimore. They have 14 different facilities and had 9 different EMS providers operating there. Now, a couple of the challenge points with having that many providers is we had to understand a little bit about workflow. We had to say, okay, how do the providers communicate with you? How do you get your data? How do you understand what performance really is? What we learned, like a lot of systems, is that there is no dashboards. They don't hold the data internally. They're relying upon either consolidated data or data provided to them in a raw fashion, maybe not in such a way that they can understand or take that aggregate or take that raw data and aggregate to something that makes business decisions. They didn't have that on site. They had little pieces and dribs and drabs. They tried to collect it, and they'd been working with all their partners, but it was hard for them to make good sense of it. They had some partners reporting really good, some partners they had challenges, and some hospitals were just saying things were bad. And if you look at the data, maybe it was, maybe it wasn't. But the other piece was the contractual relationship was not consistent, nor were the ordering processes. It was handled locally and not at a systems level. They were having challenges moving patients into, throughout, and around the system to where people were staying overnight. There was no transparency throughout the entire system, which created this challenge of, okay, we want to do better. We want to help the system. We want to have good win-win partnerships. But we have this problem of how our contracts are set and how we're collecting our data to make these business decisions. That in tune, because of some of the ways that the contracts were set, were costing the hospital about $3 million in payer of last resorts. Now, this is, in our opinion, this was extremely high, being that, you had some very sophisticated providers, but what we learned is you had some really kind of challenging processes. And those challenging processes all were from everybody not getting PCSs, not following back up on, maybe not submitting things to Medicare correctly. It was a challenge point in what we had heard and learned. Well, as we started to walk through that a little bit, we started to understand, okay, there may be a little bit of a challenge here, not only from the finance, but also how they're collecting the data. They were just relying on the EMS data. And as a firm, when we walk through this collectively, one of the things that we learn is we usually send out an information data request, and as we learn, we get the data from and we aggregate that. Well, the challenge point was out of the 9 agencies, we only received 7 agencies' data. Of that, they were all in different formats in what we received. So the data that we received was hard to really break down and aggregate in such a way that made for a full systems, a visual of what was happening. Now, we had to make a lot of assumptions. We worked with the client to understand, look, it appears to be about 40,000 trips a year that are going in through your system, outside of what they have as a Medicaid process, which is something completely different. And they had these challenges that of getting, we had the challenge of getting data, and I could only imagine what they were doing day in, day out. And because of that transparency wasn't there, what we also knew was it had made for a strained relationship. Because somebody didn't see the raw data, didn't have the dashboards, weren't able to drill down in what was going on, or there was all this back and forth about billing, data, payer of last resort. The relationships between the agencies and the health system were in such a way they were extremely strained. If you would just sit with the client for a few minutes, or listening to the folks on the frontline staff or their managers or directors, you could tell that rub was there at all times. And that rub was pervasive. So we had to walk through how could we unpack not having good data and unpack from a process perspective to help the system move forward. So next slide. So I've talked through a little bit about this, but really our critical findings were the patient movement was completely uncoordinated. It was happening either maybe somebody from the front desk was calling in, somebody's ordering as a case manager locally, somebody was ordering on the floor, somebody had ordered from another facility for a facility, somebody thought you were supposed to use this provider and not this provider. It was really an uncoordinated mix, and it wasn't centralized in its management. So the challenge point was all these different thought processes of what should be done, since it wasn't centralized, was creating a bunch of challenges. The other piece is current agencies were being managed differently at each facility. What we noticed were contracts were not system-based. So if you were one agency, maybe you were just locally working on one facility, but you weren't working between the facilities when maybe your capacity could help somebody that was at surge. So there was no usage of different resources across the system to help better manage the flow. Because of this, we would hear one day people saying, hey, I was sitting around last week when I could have helped over here. Because of those agencies not being able to work really well together and share resources or share their capacity to help the University of Maryland move their patients became quite an issue. Now, I've mentioned contracts before. Because the contracts, again, were locally and not system levels, we didn't give them the opportunity for the right performance standards. What we had dove into and understood was that these contracts may or may not have had a performance standard at that local facility, but it wasn't at a systems level. So maybe people were competing for resources or competing for times, or maybe the performance standards that were set were too stringent, or were so stringent that people are just trying to balance what they could for staffing because they'd be financially upside down if they really tried to meet that metric. So you had this imbalance of finance and performance because performance is driving cost. We'll skip the critical care because it's not quite as important, but there was a critical care component that we had to walk through. But last but not least was there was no systems of controls. There was no dashboard. There was no understanding where the resources were. There was no knowledge of how many patients were really coming in, going out, who was bottlenecked, who was hurt, or who was moving well, what each agency was performing at the end of the month. There was no Power BI tool. There was nothing that could say at a systems level, we can help manage. We all went through COVID here recently, and most of us ended up in a command post somewhere during that time period. And during our time in the command post, we used to see hospitals going on and off surge or going divert, We started to see all these different issues. But to help them from an EMS perspective, we were making manual phone calls to move patients. It wasn't at a systems level to where you could see, you were just hoping you could buy or move capacity from one EMS agency with the hopes of a phone call, but not from a systems of controls. Next slide. So what we had broke this down into for a fix was really at two different moments. What we looked at was how can really inverting the model. I keep using that term, but inverting the model. The EMS agencies previously had all the command and control. They had all the data, they had all the dashboards, they had everything. And the hospital wasn't privy fully to that data. However, what we wanted to do was invert this to where two moments in time were put together. There was a systems of controls put in place, both being able to consistently order using Epic from a software platform and to ease the path of the ordering, meaning that when you ordered, you got the right resource for the right time for the right level of service. You got the right documentation all up front. So when that went to the EMS agency, it did two parts: hospital limited payer last resort. Two, allowed for the agency to be able to bill and collect. The second side of that is that all the EMS contracts needed to be at a systems level. Everyone had to have the same contract. Now, this became a challenging moment because there were some players that moved in and out of the system at the same time. So there's a reallocation of volume. What became really interesting and became a big workflow for the group was when we started to look at all the different agencies, we had to make sure that we distributed the hospitals and the volume in such a way that A, the agency had capacity, but B, it was fine, they were financially viable. We look for a certain percent profitability, what could actually be performed within that profitability and their total volume, so that we could understand, the client could understand, meaning University of Maryland, that the EMS agencies that they were going to partner with, there would be a win-win scenario. So we had to work with that setup to make sure that whatever system we had worked with those workflows and had that level of performance based on priority, based on market rules, based on patient level of acuity. So we set those up, but we had to get that at a systems level contract. So everyone was working off the same contract, and certain providers had what we called first right of refusal at each facility. That created such a win for the system, because now, and we'll talk about this more, but in the contracts, we said the first right of refusal agency had to have said level, either 80 or 85%, I believe it was, of their own, or excuse me, 75 or 80% of their own health or own hospitals, volume, and then they could load share the capacity above that. And that was part of their compliance along with performance standards. So this allowed for the system now to utilize other people's capacity to help move patients in a timely manner. Next slide. All right, so to do that, we had to set up what we felt like those systems of controls would be. Typically, between the transporting agency and the actual system, there were a lot of manual processes, paperwork going back and forth, performance documents, aggregated data, raw data, lots of meetings going on, trying to figure out all these processes. What we ended up doing through an RFP process, we looked for a software that could actually connect the two moments and create a situation where you didn't have to pick up the phone, that everything was automated. That from the transporting, or from the hospital all the way to the transporting agencies, you would be able to just go in, click, order, put the right information about the patient, and that process gets automated to the transporting agency. When it enters the transporting agency's CAD, or excuse me, to the transportation, they can accept, change times, and by rules, either it automatically comes to them or goes throughout a second or third tier to make sure that other providers can have the opportunity, if they can have a faster response time. So the first provider, if you can do it in the window, great. If you can't, then it goes out to the other group. And then ultimately, whoever has the best time at the third tier, it would walk back through. What that allowed us to do was then, because of that software, that data was held at the hospital so they could see from a performance perspective how the system was working, how the providers were doing, help with service quality and management, and ultimately with cost controls, both in the payer of last resort and making sure the EMS agency has what they need to be able to bill the patient in a timely manner. Next slide. But to do that, as we started to walk through, what we had to keep in mind was, as much as we want to put these systems in place, the systems are good, but how's this going to impact the frontline staff? I'll give a lot of credit to the University of Maryland. They were very focused on how the front line was going to work with. And what they ended up doing was they said, let's just put a button here that auto launches into Ride Central, and we'll pull specific data out of Epic and autofill certain portions of the PCS or the transport. And as they started to work through the transporting modules, what we started to understand was this hitting the button and going through reduced phone calls, reduced multiple phone calls. And I know the word multiple, everybody wants to quantify it, but in that part of multiple, it was who's in the Rolodex, who's on first, who knows a friend. it really was a bunch of different phone calls trying to get somebody to move a patient. In this scenario, it was just one push of a button and filling out, which we've got a little bit more information on later and how much that saved in time. Next slide. And to do that, what we ended up doing, as I talked about earlier, is from that tiered system and setup, that also was derived by what was filled out in what we call the rules. What was happening is we would set up the rules being, if these different type of patients were to come in and they're dictated by the PCS form and all the 15 different characters there, whatever the medical director needed for whatever the medical director had said, maybe this is going to be ALS, or I want a critical care team to go on this, all by those rules decided on by the way the questions were answered, if it would end up being ALS, BLS, wheelchair, or critical care. Obviously, IV, cardiac arrest, or cardiac meds, whatever that ended up being, helped put that in place. So that then set whatever the parameters is going to be an ALS response, what priority, and what the expected response time would be. All of this being automated. And what ended up happening is when we started to walk through this, there was a feedback loop. So it was connected back into the nursing staff to where they could just go into the system and say, ambulance is coming here, AVL says it's going to be here, and this is the time the patient is going to be arriving. And all that was set up within the systems approach of being able to say, okay, the patient needs to leave. How are we going to get there? And what's that feedback loop going to be from those transporting providers? All while making sure PCSs were documented, were signed in a compliant manner. There was a lot that we learned about PCSs and how that Medicaid process worked within the state. But as we started to walk through those moments, what we really noticed was we needed to make sure that there was a said level of provider, and also the providers that were actually able to sign, like the doctors and nurses, and make sure they were the only ones that had access. So throughout that process, that really helped us ease the path for the frontline staff who were spending 45 minutes on a transport to spending less than a few minutes as needed. Next slide. Now, with that, what we ended up doing was, and this is actually where, as Ride Central had implemented all those different processes, this is one where they've been coming up and monitoring and setting up some Power BI. So, Ricky, I'm going to flip this over to you to let you kind of close this out for today.
Excellent, thank you. So what we're looking at here is the complete transparency of the patient transport cycle. These are actual screenshots of dashboards that are available with the University of Maryland. On this top one here, you can see they have 25,000 requests that have come through. And this one is giving you a view of on-time performance. What this 86.8% completion percentage is the completion percentage that the primary vendor for that facility is completing the transport. So even though one thing that was very interesting when we put this thing in was each facility traditionally had 1, 2, and there was a couple that had 3 vendors that would service that facility. And that we were noticing that the primary transport vendor was actually only doing about 70% of all the runs out of the facility prior to Ride Central going live. Now you can see that the primary vendor is doing 86.8% of the runs. And we have not 1, 2, or 3 vendors doing the other 14% of runs, but we have all 12 transport agencies running calls out of that facility now on a backup basis. So therefore, you're seeing system utilization go up. As you can see here on this, we started off on time percentage down in the 67%, and it's worked its way up to 74.5% as a complete system. But the critical function here is, look, even when they're late, their average pickup time and lateness has gone from 22 minutes to 8 minutes. As you most know, most facilities don't consider a transport company late if they're there within 8 minutes, and that's their average lateness. So instead of moving patients sometimes 18 to 24 hours out, they're actually moving patients at times that are being requested, and their primary vendors are doing most of that work because we're requesting The automated rules are getting the right level of service. They can staff to the level of service that they need. They're getting the information they need, and they're moving those patients efficiently. This one here is a facility view. So you can see out of this facility, you can see the number of trips, the completion percentage by their primary vendor, the percentage on time, and they're only 9 minutes average delay in picking up a patient after the requested pickup time. And now they're down to 4 minutes. So they're essentially on time every time. And then this would be a transport agency view, how many trips they've done, how many they do as the primary vendor out of their facilities, what their on time percentage is. And you can see over the course of time, on average, they were 24 minutes late, and now they're 4 minutes late. So the efficiencies have really grown within the system. This view over here is just a quick view of what, if you are in a transfer center or you wanted to see all the calls within the system, it gives you a really granular view of every single transport, the stage they're in, the ETAs, everything that you want. Those are all role-based permissions. What you get to see is based on the permissions that are there. Now, here's some of the system results that we saw. Patients are being moved in a coordinated effort with all 12 available transport companies, and 86% of all of those requests are being handled by the primary vendor. The systems are integrated and standardized, and the transport process is the same. It doesn't matter which facility you're in within the University of Maryland's healthcare system. When you go to create a booking within that Epic EHR and you click the link, it pops up the exact same screen, it asks the exact same questions, and it has conditional visibility. These questions are based on the patient's needs. So if I click that they have interventions during transport, it then opens up all the questions around those interventions. If I say they're on a ventilator, then it's going to open up questions about the ventilator. I only see what I need to see. It makes it very easy to flow through the screen and book a trip with all those compliance factors that we need. Based on those questions, it completes the electronic PCS forms. So it's completely standardized all the way across. Everybody does it the exact same way. The patients are being moved, as you can see within those charts, within their contracted performance requirements. They're on time, and even when they're late, they're really on time because they're closing that window. The transport vendors are, and they're working together in that ecosystem as a team and not so fragmented and convoluted. One of the things that's make that possible is we've absolutely eliminated the incorrect level of transports. The only way you get an incorrect level of transport is if you don't fill out the transport request forms correctly within the system, or if the information is wrong within Epic that's pushing over to the transport vendors. That provides for optimization of the utilization of the resources by the transport vendors. And then one thing that's completely important is all agencies have complete visibility of the transports that were within their systems. And then most importantly of all is this one right here. Reduce time on task for end users. I had the opportunity last month to go and do a follow-up site visit with University of Maryland after go live. They've been on the system for about 8 months. And one thing that was consistent as I went through each one of those facilities, and I know we're running out of time here, so I'm going to wrap it up, was that the end users, the case managers, the nurses in the ER, the unit secretaries said, what complex processes to ordering transportation that used to take them 45 minutes to an hour, sometimes 2 hours, is literally less than 60 seconds. All the forms are there, everything's completed. And so it's reduced the time on task. They enter it and it goes through all the transport vendors and they're done. So overall, system results have been fabulous for the University of Maryland. Now, it's really time to evolve how you handle your patient transports. If you have any questions or want a demo, you can always reach out to me. This is kind of the salesy side of it. I wanted to give you a bunch of information on modern transportation systems and how they can solve those problems. And I'm going to turn this back over to Anthony so he can wrap up and give you back the rest of your day.
Thank you, Ricky. Get myself unmuted and back on the video. That was a great presentation. It really shows us how we can definitely better ourselves through the use of this technology. We didn't have a whole lot of time for questions today here at the end because there was so much great information. But if there were some, I know Ricky got to a lot of you in the chat as we were going along and answered those as they were coming in. But if we had some other ones, we will get those sent out responses in email. And if you have other questions, be sure to reach out to Ricky or to reach out to Todd for more information on that. Thank you again, TraumaSoft, for your partnership and for bringing this great content to us all today. It's very informative. Also, like to say thanks to our learning partner, Ninth Brain, and our premier media partner, EMS One. In case you missed it, we do have a few spots left in our spring 2024 ASM program. It begins again on January 22nd, 2024, and you can learn more about it and register at fitchassociate.com. We will also be opening fall registration in the very near future, so be on the lookout for that. And also be on the lookout for more information about next month's webinar, which will be coming soon. This webinar will be held January 16th. We're looking forward to bringing you another great webinar lineup in 2024. I hope everyone has a very safe and happy holidays, and thanks again for joining us today. Stay safe. We'll see you next time.